So continuing with the general surgeries, let me set the timer. Cool. Now, actually, we have iodine deficiency. Oops, sorry. Yeah. Now we have iodine deficiency. And sometimes there are goitrogenic drugs also. Uh, drugs, and if it is seen over a long period of time, it may produce papillary carcinoma, and external radiation and administration of radioactive iodine can also result in thyroid carcinoma. So that, and there is ionizing radiation in children or young age directed at the thymus or the cervical lymph nodes has been shown to definitely carcinogenic for human thyroid. So if you are putting on radiation, yes, if you're putting on radiation to thymus or to the cervical lymph lymph nodes, they're definitely shown to be uh, carcinogenic for the human thyroid, and that is why the administration of I-131 iodine for treatment of hypothyroidism should be restricted to patients above the 40 years. So 131, we all know that it is to be given more than 40 years. That we covered in radioactive iodine. Now the metastatic lesion of the thyroid cancer closely resemble the normal thyroid tissue rather than primary carcinoma. That is why metastatic enlargement of the deep cervical node in case of papillary carcinoma almost looks like normal thyroid and was previously called lateral aberrant thyroid. So we have our neck, we have thyroid gland. Suppose this is a thyroid gland, and we have the lymph nodes here. So lymph nodes of the neck. So there is metastatic lesion of the thyroid cancer closely resemble the normal thyroid tissue. That is why metastatic enlargement, if it has metastasized to deep cervical nodes, in case of papillary, suppose the person has papillary carcinoma and it has metastasized to the deep cervical nodes, they almost look like normal thyroid. So they will look like normal thyroid. And it was previously called lateral aberrant thyroid. That means it's normal, but it's actually metastatic. They were previously known as lateral aberrant thyroid. Now, spread of the thyroid cancer, it could be direct by infiltration, seen in many anaplastic carcinomas, and papillary carcinomas leads to show direct spread. So there is direct spread. There is direct spread for anaplastic, least by papillary carcinoma. Direct spread, okay, and then there is lymphatic spread. So papillary is notorious for lymphatic spread and it spreads to the cervical lymph. Here also we have seen that papillary carcinoma, especially when they metastasize to the deep cervical lymph node, they, they look normal, but they looked normal previously and they were called lateral aberrant thyroid, but it could be papillary carcinoma. So papillary carcinoma has predilection to lymphatic spread to the cervical lymph nodes and blood spread. Blood spread is by follicular and anaplastic. It occurs by angioinvasion also. Mm. Now, papillary carcinoma, most common and most they're the most common and most slow growing thyroid cancers. Most common. They have samoma bodies, localized deposition of calcium in connective tissue is present. It's multicentric. The multicentricity of the primary tumor is a most important feature due to lymphatic spread uh, in the reach of intrathyroid lymphatic. So papillary carcinoma actually shows multicentricity. Okay, the size of the primary lesion has more impact on the prognosis than lymph node metastasis, and we do actually near total thyroidectomy for treatment of for surgical treatment if we have to. Then we have follicular carcinoma. We have follicular carcinoma. It's the most important feature is capsular. It actually has capsule and it is angioinvasive also, and it shows good response to the radioiodine also. To make the radioiodine treatment more effective, all normal thyroid tissue should be removed surgically. So we do total thyroidectomy in here. We actually do total thyroidectomy in follicular, and it has for hand generation shows good response. Anaplastic is basically it may develop from previous nodular goiter. Presence of mitosis is a characteristic feature. Anaplastic. It is known to spread directly and involve the neighboring structures. Land is often fixed and shows poor movement on swallowing. It becomes hard in form. And form. Okay. Medullary carcinoma. It's the main characteristic feature. Its non-follicular histological appearance. Non-follicular histological appearance is there. Non-follicular. Yeah, because parafollicular cells are there. No? Its origin from parafollicular C cells and its secretion of calcitonin. So calcitonin is also produced medullary. Calcitonin is produced. Yeah. So all other disorders of the thyroid have high predilection for females except for the medullary carcinoma that shows actually equal sex incidence. So equal sex incidences, and it often shows presence of the amyloid in the stroma. There's amyloid structure deposits in the stroma, and C cells hyperplasia is considered to be precursor of the medullary carcinoma. Now, metastatic lesion of the medullary carcinoma in bones is osteoblastic. So it actually bones को जाता है. Yesterday we learned about neuroblastoma, which spread to bone, liver, and one more. I can't remember. Bone is definitely there, and liver was there, and some like some nerve or something. Can't can't recall. Majority of the patients suffer from diarrhea. Ectopic production of ECTH by the carcinoma can has been demonstrated. So there was also ectopic, and it forms part of the MEN2 syndrome, syndrome, and it does not respond to thyroxine treatment and radioiodine or external radiation. So total thyroidectomy is the treatment of the choice. So इसमें भी हम total thyroidectomy करते हैं. We have acute suppurative thyroiditis and we have Hashimoto disease. There are different kinds of thyroiditis. Suppurative Hashimoto, which is acute, autoimmune thyroiditis, subacute thyroiditis, or de Quervain's disease. There is Riddle's thyroiditis. So there are four kinds. So there is one acute one, which is basically it almost invariably follows acute upper respiratory tract infection. So upper respiratory tract infection is there. We have Hashimoto disease, Hashimoto's disease. Then we have in Hashimoto disease, it is also called lymphadenoid goiter or chronic lymphocytic thyroiditis. It's chronic lymphadenoid, and it's the most common form of thyroiditis. Most common thyroiditis. And it's autoimmune disease in which the thyroid gland becomes sensitive to its own constituents. So it's also genetic predisposition is there. Majority of the carcinoma associated with this condition are papillary variety. There are high titers of anti-thyroid antibodies. So it's since it's autoimmune, there will be antibodies to the cells, and the modified epithelial cells are seen microscopically. They are known as Ashkenazi cells. Ashkenazi cells. Ashkenazi cells is a feature of Hashimoto's thyroiditis. Now they're modified, and also like in the Hürthl cell, no, they're seen. So Hashimoto disease, there is increased incidence of pernicious anemia, rheumatoid arthritis, hemolytic anemia, myasthenia gravis, and all. But also like Hürthl cell, it's a variant of follicular adenoma, and Ashkenazi cells are seen over there as well. And Hashimoto disease maybe there is Ashkenazi cells. Now there is subacute thyroiditis. Subacute thyroiditis is called granulomatous thyroiditis because it's some considered to be viral origin while other considered to be autoimmune. So in question always de Quervain is viral in origin. It often follows upper respiratory tract infection like the acute suppurative thyroiditis and specifically treated with corticosteroids also. Now Riddle's thyroiditis, it's a rare form. Riddle's thyroiditis, it's a rare form. It's a rare form in which inflammatory process extends beyond the limit of the thyroid and involves the surrounding structures. There are usually three places where the aberrant thyroid tissue may be formed. So we do have aberrant thyroid tissue, which is like thyroid tissue not on its normal place, but somewhere else, but it's normal, like normal. It's not thyroid, aberrant thyroid tissue. So we have lingual thyroid. It could pose problems. It has to be removed, but it's not like metastatic or something, no? Yeah. So thyroglossal, ectopic thyroid. Isn't this the same? Thyroglossal, ectopic thyroid. And then struma ovary, which is a teratoma. Struma ovary. It's actually a ovarian teratoma, in which thyroid cells are found, or thyroid tissue is present, and it is malignant. True. So my assumption was wrong. Malignant. Malignant. Okay. So it can be malignant thyroid. There's a thyroid, lingual thyroid, there's thyroglossal, ectopic thyroid, there's struma ovary also. For thyroid swelling to be palpable, it must be at least 1 centimeter in size. So with it at least 1 centimeter in size, it will be palpable. And with and in the vein thyroiditis index, thyrotoxic index, we learned that on palpation, if it's palpable, then +3 score is given. Now miscellaneous points about all of these. The calcium is a goitrogenic in places where there are plenty of chalks and limestone. Goiter is endemic, true, which is like literally true. Also, Brassica family plants which are in the Brassica family, Brassicaceae, like the cabbage, red plant. I mean, all of those things that come under it. Now, excess ingestion of the thyroid may develop goiter with thyrotoxicosis. This is Jod based. Oh, that's a good question. Jod based. Oh. So there is excess ingestion of iodine with thyrotoxicosis. That is deaf and goitrous. If a person is deaf, imagine a person who is deaf and who has goitrous. These spellings, man. That's Pendred's syndrome. Swelling of the thyroid gland always moves with the declaration except in the following cases if it's intrathoracic extension is thyroiditis extending into the adjacent structures of the carcinoma which is fixed, and that means that this invasion, it has invasion of this in the surroundings. And thyroid active scan is very helpful to differentiate hot form from cold. Hot nodules are likely to be carcinomas and indicate it to be toxic nodules. And cold nodules are more suspicious. They may be cystic or solid. Incidence of the carcinoma in cold solitary swelling is about 15 to 20%. So, radioactive scans. We have hot, we have cold, they are malignant, they are not sure, cystic, could be solid. That way. The real-time ultrasonic scanning is mainly to differentiate cystic from solid and to differentiate between we do USG ultrasonography. Now needle biopsies. So there are three major techniques used. needle biopsy. There is FNAC, which is fine needle aspiration cytology, and there's large needle aspiration cytology, LNAC. There's FNAC and LNAC, and there is cutting needle biopsy. Cutting needle biopsy. So this method usually allows the cytologist to differentiate neoplastic from non-neoplastic. So new to non-neoplastic. Then it could be like papillary, medullary, and anaplastic. They are claimed to be easily recognized. Also like histopathologically, we can only determine between follicular adenoma and carcinoma. Otherwise, it's not possible. So yeah. The main limitation of this inability to differentiate between benign and malignant follicular. So we cannot differentiate between benign and malignant. That's why follicular, non-follicular cannot be determined. Sorry, follicular adenoma and follicular carcinoma cannot be determined because of the lack of its because of its inability to differentiate between the benign and malignant. Otherwise, the other ones like papillary, medullary, and anaplastic, they can be recognized. Okay. Now, in case of the simple goiter, sudden pain with increase in size of the thyroid, simple goiter is there. There is pain and size is also increasing, which may be because of the hemorrhage within cyst. If it's a cyst, there will be hemorrhage or degenerative nodule. Nodule is there, so that. Yeah, again, anti-thyroid, they are given below 45 years, and radioactive thyroid, they're above 40 years because like ionizing, they can cause thymus and lymph nodes can be affected and can cause carcinoma of the human thyroid. That's why we don't give radioactive thyroid. They're given above the age of 40. So how much time is left? I have 2 minutes left. This is done. Actually, thyroid is all done. Shall I start with the salivary glands? 2 minutes. Let's just do a little recap. No, I won't be able to finish. 2 minutes. Let's just like finish.